I'm Dr. Demetrio J, Aguila III. I'm the host of the Direct Care Movement podcast, where we are going to talk about where money and medicine interact and where they intersect. We're going to talk about topics that maybe you were afraid to talk about, or maybe topics and questions that you wanted to ask, but you didn't know who to ask or where to ask, or if you could ask. We're going to cover those things and probably a bunch of other questions that you didn't even know that you wanted the answers to until you heard them here. We're going to dive into that today, and I'm really excited to have with us Dr. Phil Eskew. He is, well, number one, he's a hero of mine. Number two, he was instrumental in helping our practice succeed, and I just want to welcome him onto the show today. Phil?
Thanks, Demetrio. I'm happy to play a part in the direct primary care movement, and glad that DPC Frontier could be of use, and that's the intent behind it. So it's good to join you, and I've seen that you've interviewed many colleagues. I noticed one of them was Keith Smith, who's been if we're going to say heroes, he's been a hero of mine for a long time too. So you've had an impressive group of people so far. So I'm happy to be a part of it.
Well, thank you for adding your name to the list here, Phil. We're excited to have you on board. Why don't we start with you doing a quick introduction? Tell us a little bit about your background and how you got involved in direct care and you know this whole evolution and revolution.
I'm a family physician, but I'm also an attorney. I grew up in a house with two physicians as parents. My mom's a pathologist, my dad's a family physician, and I hear them talking about how much they enjoyed medicine and how frustrated they were about a variety of things they felt like they were powerless to change based on the system structure in place. So thought that I wanted to do medicine, but also wanted to be in a position to overcome some of the hurdles they complained about. And that was the reason undergrad why I didn't just major in chemistry, but also did accounting. And it was the reason I kind of did the diversion before med school of getting the MBA and then ultimately the law degree. Wanted to be able to use those things to sort of pierce through some of the red tape, and instead of being fearful legally, be more aggressive and aggressive for physicians and patients for both of them against the system. And direct primary care became an interest of mine. I think I would say right before med school, even I got in an argument with a fellow law student about whether or not it was or wasn't insurance, and it was clear to me just how easily people were confused about it at the time. And I went to law school at WVU in Morgantown, West Virginia, and the reason it was being discussed, we're talking 2006, 2007, the reason it was being discussed so early then is that West Virginia was actually the first state to have a law in the books about this. And so this guy was contemplating putting a law review article together on it. So that was my first argument about it. I'd always known that I kind of liked it. That was the first time I'd heard that phrase. The physician who was doing that in West Virginia, his name was Vic Wood. He's a DO. He's a graduate of the same osteopathic school that I went to in Lewisburg. So a variety of serendipity, I guess you would say, and geographic serendipity, in that I was sort of where a lot of this stuff started. Most people are familiar with Garrison Bliss, who practices out in Washington State, and Brian Forrest in North Carolina, and there were a few others who were doing this really early. But West Virginia was actually the first state to have a law. It was just really bad about what direct primary care was, and then Washington followed, and then we've had, the majority of states now have law in the books.
That's awesome. So, in direct primary care, I mean, particularly for medical students and residents these days, I think there's a growing body of our listening audience that have at least heard about direct primary care. But despite the fact that it's been around, I would argue that it's been around since the beginning of medicine. A lot of people still aren't familiar, at least with the term. And there's still a significant number of people who aren't familiar with the concept. So can you kind of outline that for us?
Direct primary care was defined out of obligation. And if it were up to me, we would have called it something else, because it has lousy search engine optimization. At least it did initially. It doesn't necessarily tell people exactly what we're doing. And most people, the first time they hear about it, they say, "Oh, you mean concierge?" And so we constantly have to say, "No, that's not what we mean." So I'll start, like, if a patient asks me this in the elevator, what's the quick pitch? It's a monthly fee for all-inclusive primary care. We're totally third-party free. We're outside of your insurance. And if we charge you for any ancillary items, we've got that menu on the wall behind us, and you know exactly what it's going to be. There are no surprises. How does that really translate? Concierge practices, for the most part, are still billing insurance in a traditional fee-for-service manner. The monthly fee is for non-covered services. So that's the contractual game they play. And that does lots of things for them. It keeps their practice inefficient. It results in better care to some people compared to others. And it actually makes the insurance commissioners happy because insurance commissioners view this as an obvious bottleneck and they're not worried about too many people seeking care at the same time because you're still charging that fee for service insurance piece of it. If you take away the insurance piece, obviously you get a lot of administrative efficiency. You can now lower your price points quite a bit because you don't have the overhead. But you do get the insurance commissioner's attention because now they say, well, what if you allow 5,000 members that you clearly can't take care of, and there's yet another COVID wave, and you've promised all these people you're going to help them, and now we're going to have to watch you fail. So because of that fear and that misunderstanding, you've got laws on the books defining DPC as outside of insurance. If you start looking through state codes looking for definitions of concierge, you won't find one. Nobody ever needed to define it. The IRS and some other groups would love to define it so that they could attack it in different ways, but they've had trouble doing that, which is why it's persisted. So we've done it not because we want to be exclusive and say this is the way to do primary care. It is a way. It is, in my opinion, the best way. But there are lots of different ways to do it, and there are lots of ways to be third-party free, especially if your scope is more limited or you're more specialty focused. So I have to remind people of that when they might want to have their practice in the DPC mapper, but they don't have any kind of membership offering at all. And I say, well, that's not what this is for. The patients coming here are looking for broad scope primary care membership options.
So then effectively, direct primary care is kind of like a gym membership, right?
Mm-hmm.
So
Correct.
walk us through some of those parallels so that, maybe some of the people that aren't as familiar with the concept, maybe they can understand it a little better.
So if I have a patient who's 53 years old, has some mild chest pain and some shortness of breath that comes into my office today, I'm going to do the EKG. I'm going to do a spirometry. I'm going to do a 6-minute walk test. And that's not going to cost him anything extra. A typical practice is going to code each of those things and find a way to charge extra. If he asks more than 2 questions, they're going to change it from a 99213 to a 99214. And if he dares to ask 6 or 7 questions, they'll make it a 99215 and charge even more. We don't do that. It's all a predictable monthly fee. If we have an additional charge, it's for something that we've itemized. So most commonly labs. If we're doing an autoimmune workup for lupus, that ANA might be just $5, but I got to warn people, if that's positive because the ANA's, 1,000 dilutions, and now we need to order the double-stranded DNA antibody and some other things, then there's going to be a pass-through price for that. So labs and medications we pass through at cost. Radiologic studies, we don't do them in our office, but we've got relationships with other radiology groups where they will pass those through, whether it's $50, $70, depending on what we're ordering. A brain MRI in South Carolina you can get for around 600.
That's awesome. I mean, those numbers are, they're shocking, I think, for a lot of people, particularly for, the residents and the rest of our audience that are accustomed to seeing that decimal point moved over 1 or 2 spots.
Mm-hmm.
So, I know Keith Smith talks about this a lot, about how healthcare isn't expensive. It's health insurance that's expensive.
Mm-hmm.
Talk to us a little bit about that difference.
I think health insurance has regulated itself to death, and we've got an interplay here between federal and state law where it confuses a lot of people. If you've got health insurance through a large employer that's operating in multiple states, you have what's called an ERISA plan, and that makes it cheaper for the employer, but it makes it really difficult for you to sue the plan if they've wronged you, because you can only sue for the price of the surgery they should have paid for. You can't sue for the sequelae that came from the delay, or
Mm.
even a wrongful death action where there would be punitive. So a lot of that is blocked under ERISA. So I tell people, as a law student, I grew up hating ERISA, and I mostly still do. There's some terms in it that work out for DPC as well, but that's been a problematic one. States are allowed to regulate insurance. Big states, because they're big, will have several plans to choose from. Small states often don't. They may only have one. So our market has failed us on the insurance side in many ways, not just in healthcare, but in other aspects of insurance too. If you watch the news, you'll see that if you're planning to buy a house in Florida, you better not, just plan to eat it if you lose it, because you're not going to be able to buy flood insurance. It's just priced itself out. So I would not be surprised if at one point the traditional health insurance market largely dies under its own weight. And you're having other entities come up to help bear this risk in more predictable ways that are capped. And when you look at the data, it's kind of astounding. Most people think, well, I'm going to get health insurance because my employer has it and it's subsidized, and I'll get this high deductible plan. And even though that'll hit me into the tune of 6 to 10 grand initially, at least I'm not going to go bankrupt now because I have insurance. Most people who wind up with this multi-month ICU stay and dramatic recovery, they're bankrupt, and they had insurance. So
Right.
it doesn't protect from that most catastrophic scenario, which is sort of survival plus bankruptcy, I suppose, which is arguably the main intent of it. So I've been pretty disappointed with what the insurance industry has done across the board. And we help patients navigate around that in many ways. We don't, a lot of times we can't tell them this is the best plan for you, but we can point out how they fail. And you can point out that health sharing ministries are an option. There are other limited indemnity plans that are an option. And so people are more and more interested in those alternatives. And the more we ask how much it costs, the cheaper it's going to get across the board in terms of the care that we're seeking. So we need more and more patients to pursue price transparency, and we'll get more of it. And then we won't feel like we need the insurance industry as much, because a lot of people feel like they need them to be protected from this abusive pricing scheme, and they're unaware that they can litigate their way to price transparency. There's a provision within the HITECH Act, which modified HIPAA, that I like to talk about, that says, even if you have insurance, you're outside of limited circumstances tied to either Medicaid or having an HMO in some states, depending on the state law. But outside those two narrow circumstances, everybody else can use their rights under HITECH to mandate that the specialist or the ER or whoever they're seeing give them a cash price outside of the insurance system.
So let's talk about that a little bit more. So why would a patient want to do that?
Well, they may have a high deductible plan, and it's a bit of a catch-22. And I'll give you one of the more common scenarios here. Let's say I've got a patient with low back pain. We've done some conservative things. We've done physical therapy, and now they got radicular symptoms, and they got a little weakness of the right gastroc, and maybe their reflexes are a little bit asymmetric. And I'm like, I'm sorry, you're going to need an MRI and you may need surgery. If this patient hasn't spent anything on the plan this year, and it's December 11th, like it is today when we're talking, then doing this MRI and running it through insurance might mean that they get a bill for about $2,200. And they might even be duped into thinking, hey, I got a deal because the sticker price on this was $5,000, right, until I tell them the cash price was $600. So there's this irony where you can spend more money now to try to hit your deductible faster because you think you're going to go high enough above it later on that you'll come out ahead. Or you can look at it and say, well, it's already December. I haven't spent a dime. I'm not going to have surgery this month anyway. So I'm going to pay the $650 cash because I come out ahead. And how do you get the ability to do that when the radiation center looks at you and says, oh, you've got a BUCA plan and we have to charge you per the plan because we signed a document with the plan that promised we were going to, follow their rules. You say, well, that's fine. And here's HITECH. This is federal law. That comes out ahead of your private contract.
Well, that's awesome. That's really helpful information. So it sounds like one of the key components in revolutionizing the way we finance healthcare is education, or maybe more specifically, combating ignorance, and not just ignorance on the part of the patients, but also ignorance on the part of the people delivering the care, people like you and me, for instance. What are your thoughts on that?
I do think for far too long, if I'm looking first at physicians as a group, we have said, going back to the first year of med school, don't worry about the price. You learn all the physiology, you learn all the rest of this, the price, the policy, the politics, the administration. You can't handle that. It's too much. You let other people deal with it. And as a consequence, we've got a system that's not communicating well, and patients are lost, and we're lost. And the more we take that back to working on behalf of our patients, being their advocate rather than contracting out that work to somebody else and pretending that they're going to have the clinical wherewithal to get through it, the better we're going to be. So we know, if we stick with the MRI example, let's say all the MRIs for some reason were now $10,000. There was a big wait list. People were coming from all over, like maybe all the MRIs in Canada broke or something, and everybody's coming down here, or whatever silly scenario you want to come up with. What
Sure.
else could I do? Well, there's a nerve conduction study. You can get more information that way. There's almost always an alternative study that can be done, and there's a different price point and a different set of risks that go with that. And very often we really don't dig into all those details because we feel like we don't have the time, we don't have the resources. But if we start making it a habit to look at this and look for those resources and discuss that from day one, then that should be a part of it. If I were writing, who knows where exams are going to go one of these days, but exams in med school are a pet peeve of mine because a lot of it is just memorization. It's not necessarily clinical thought, which is far more valuable. You don't need a memory now. Anybody can look anything up really quick. So you need to know what the right questions are and where to go to get the information and how to interpret it. And the right answer, how do I put it? The right answer is one issue. Like, you don't want to hurt somebody, of course, but how quickly you arrive at it and how cost effectively you arrive at it are also important. Because if DPC shingle number one diagnoses a patient with this chronic condition in 2 weeks, spending $30 on labs, and the second practice takes 4 weeks and spends $5,000, they both got the right answer,
Right.
but somebody's doing a much better job.
Sure. So I think we can all agree that you're pointing out a number of different scenarios where our system is, as some people would describe it, they'd say it's broken, and it's not functioning the way we want it to. I would tend to agree more with Dan Paul's take on this, that the system isn't actually broken. It's perfectly designed to do exactly what it currently does. The problem is that what it does isn't necessarily what most of us actually want.
Mhm.
And so, you've been involved in direct care for a number of years. In an ideal scenario, if you were emperor, what would it look like? What would our healthcare system look like, top to bottom? And how would we address these questions that pertain to finances? What would that look like in your scenario? And if you could make the shots, make the call.
Everything in the way of price transparency would be gone. In 2024, I see no reason for pharmacy benefit managers to exist. We can achieve a market really quickly and much better without their involvement. They may have had a role initially decades ago when they first started, but now they're just part of the price obfuscation problem. And to the extent they could have had independence in value, it's gone because they've all been vertically integrated with the payers. So the big three have 85% of the market share, and they were purchased by pharmacy chains and insurance companies that have just vertically integrated down the line. And all of those large entities are plugged into the matrix, if you will, and that they need you to need them. And the only way they do that is pricing fear, because they don't add value anywhere. I've never had a prior auth come back and say, "Oh my goodness, I had no idea. Thank you for educating me about this drug that I tried to prescribe like a doofus." Like, it's never come back and taught me something totally new. I've had pharmacists call and say, "Hey, this patient's on these other 2 medications. Did you know this? Do you still want to do this?" And those conversations are good. But the AI style prior auth system is a joke. It's supposedly there for quality, and we all know that's not true. It's there to be red tape. It's there to deny things. And utilization management could be good, but often isn't. And it's often in the way of surgeons trying to get approval for procedures and delaying care as well. And it's supposed to be a collegial process, but the idea that anybody truly objective is on the other side there is debatable because they're representing the payer. So you represent your patient, they represent the payer, and it winds up being pretty adversarial, almost like two attorneys in a courtroom. So that's not what it could be. If you wanted to redesign the system ground up, I think we would look at it and say, well, there are, do people have a right to medical care is usually the first question you ask. And a lot of people are tempted to say yes, but if you say yes, that means you're mandating somebody else give you that care. And I can't think of anywhere else where the United States is doing that. If you're accused of something in a criminal capacity where the state is coming after you for a violation of law, then you do have a right to an attorney, even if you can't afford one. But that's after the state has come after you. You didn't have a right to an attorney for your own pro se civil case against Walmart or whoever you might be suing. So, do you have a right to somebody see you in healthcare? For the most part, the answer winds up being no if you look at the law as it is on the books. Now, there are exceptions. People who are incarcerated have a right to healthcare because they can't go elsewhere to seek it. So there's a constitutional law argument there. And then through EMTALA, people have a right to emergency screenings, which they confuse with care, which can actually be delivered by a nurse and doesn't require you see even a provider. So that's where the law stands right now. If you're adjusting that from the current system, I think the government probably has some sort of interest in the overall population health. And that's what you're going to see with RFK doing a lot of stuff with the new administration, likely. Banning substances that are just clearly unhealthy and the risks weren't disclosed, doing the research to figure out what is or isn't healthy and disclosing that to people so they can make up their own mind. If you're going to have the government providing care, what should it provide? Probably the really cheap, easy, high yield preventive care, the things that you already see under USPSTF level A and B that were mandated to be free through insurance companies and are largely free already in Medicare. So I could see them doing that kind of stuff long term. And the sad reality there is, I don't know about your clinical experience, but I've got a wide mix of patients, and some of them will come in and you got to drag them to do all that stuff, even though it's free. And other people come in saying, I want to do everything. I want you to order every lab you got. And I have to tell them, whoa, you'd run out of blood. We can't order everything.
Right.
We can only go so far here. And you've got to reach this medium. And the people who need to do those other studies the most are often the most reluctant, even when it's free. So I can see a government role there and having that kind of stuff. And I can see some sort of government role for, end of the line, emergency only kind of triaging. And I think we're going to wind up, whether we want to or not, regardless of the administrations that are in power, we're going to wind up with some kind of two-tiered system where you've got some preventive stuff that's largely free if you have the initiative to take care of it. And then you've got this emergency system that nobody wants to be in, but it's free. And then you'll have a different privatized system that hopefully is more price transparent and more affordable over time, as a lot of the payers just get pushed out because they're not adding value.
Sure. So then let me ask you this. You're a direct primary care doctor. I'm a direct care surgeon. I've noticed in my practice that since we switched to purely direct surgical care, the relationship that I have with the patient is radically different than it was before. Now, as I understand it, and I was a primary care doc in the Air Force for about 4 years before I became a surgeon, and so I have some sense of of primary care. Obviously, you've got a lot more experience with that. But one of the things I often hear from many primary care docs, whether we're talking about me talking to a resident or somebody who's been doing this for 30 or 40 years, is that, well, yeah, of course, exercise and diet are the best way for us to manage and prevent so many of these problems, but I can't ever convince patients to do it. Since you started doing direct primary care, have you noticed a difference in the buy-in from the patients and the success with preventive measures and other measures besides pharmaceuticals, to let's say, take care of high blood pressure or high cholesterol or other things like that?
Yes, yes is the answer. So the more time you spend with patients, the more likely they are to gradually buy into some of these things. I think so. I practice in the direct primary care space that's often tied to large employers. So we have some patients that join independently on our own, and those patients are some of my favorites. And they're some of the most interesting clinically, and also most motivated or activated or whatever word you want to use there, because they're paying the monthly membership fee on their own, and they came in with an issue that they want to solve. And once you solve that, then they start working down the other things that were on their list as well. So once you figure out that all that pain in your foot was gout, now we start talking about metabolic syndrome. Now we start talking about weight loss and how that's also going to prevent your gout flares when you drop your carbohydrate intake. And so we dig into all those things. And when you have success with a few things, they want to keep pushing it because they realize, okay, we're getting somewhere here for maybe the first time ever. I'm actually getting somewhere in a medical office. And then you've got other patients that come to you because the employer's paying for it. So they say, oh, okay, fine, I'll go over here. And they don't really think anything's wrong with them. They might be overweight, they might have some hypertension, but it's asymptomatic. Maybe they're even pre-diabetic and some metabolic syndrome. And as you spend more time with them at those wellness visits and educate them, then hopefully you can get them to where they're a motivated patient as well. So that can be a little bit harder. I often say that if metabolic syndrome caused immediate 10 out of 10 back pain, nobody'd be overweight. But because it's so subtle and everybody thinks they're fine, we get where we are.
Sure. So for our audience, for the medical students out there that are trying to decide what they want to go into, I've heard a growing number of medical students tell me that they choose the particular field they want to go into, at least in part because they're looking back at this huge mountain of debt, and they're like, wow, I mean, there's no way as a primary care doc that I could ever get out from underneath that debt. And obviously the debt itself is another question altogether. We could dedicate a whole episode just to that. But setting that the how we got there aside, what do you say to the medical student who says, well, everybody tells me primary care is dead and it's a dead end, and there's no way for me to have a decent living and pay off my school loans and whatever else as a primary care doc. So I'm going to go become a left thumb specialist, and just do a whole bunch of fellowships. So all I work on is the left thumb.
Well, if people keep playing video games, I guess that could work out. But I would say that don't listen to someone who's working in a system that you're not going to be a part of. If you've decided really early on that you're going to be in that system and you're just going to tolerate it all in spite of your awareness of its failings, and you feel like you need to hyper specialize in order for your own mental health to allow you to continue that career, I guess that's what you're going to do. But DPC is a growing movement, and even outside the primary care setting, direct care in any number of its varieties is increasing. I think the fields that you pick that give you less and less autonomy, where you're stuck in the large system, are going to become less popular over time. And the pandemic did some weird things. It took psychiatry, which used to be not very popular at all, and now it's really popular because the reimbursement rates went up, the demand went up, and oh, by the way, you can work from home. So there are things that are hard to predict exactly where we'll move. A lot of these specialties are driven by a handful of really popular procedures. I think there are a variety of ways to screen for colon cancer now, and colonoscopy is still the winner. But if there were an alternative universe where colonoscopy weren't the winner, then we're going to have a lot of people that did gastroenterology that are now looking for something else to do. And in the primary care, you are already naturally positioned to go where you are needed most.
Sure.
You have to learn a lot. You have to learn a lot about a little bit of or learn a little about a lot of things. Excuse me, and be able to take it as far as you can. And if you try and do primary care with an urgent care mentality, you will be bored and depressed, because you'll only be able to do 20 or 30 things that you can handle in 5 to 10 minutes. And your skills, to the extent you gained them in med school and residency, will start to atrophy. if you don't work up the complicated anemia, you'll forget how to do it. So in this model, you have the time to do that, and you have the time to make yourself smarter. At this point, I've got 4 years of med school, 3 years of residency, and 9.5 years post-residency. And where did I learn the most? The 9.5 years post-residency, because I kept at it. You learn enough that you hopefully aren't hurting people, at least not as high a rate as you otherwise would have by the time you finish med school and residency. And from then on, you have to keep teaching yourself. And if you're in a model where you can't do that because you're boxed in, because you don't have time, because they want your scope to be narrow, because they employ 50 specialists who you also need to refer to, or the hospital won't make money, then you won't have any fun, because you'll know that you're not doing the best you could for your patient.
Sure. So you mentioned already your background, your training, your experience, and you have a means for getting that word out to a whole bunch of other people. I mean, I am a beneficiary of the work that you've done. My patients that I've been seeing that these days come from literally all over the world have benefited from the work that you've done. I stand on the shoulders of giants, and you're one of those giants whose shoulders I stand on. And I want to thank you for that. I want to thank you for that, so that the whole world knows you've made a difference, not just for the patients in your practice, but for people all over the world. Now, we've got medical students, we got residents, we got fellows, we got people who are unhappy in their jobs as attending physicians, who are thinking, you know what? I'm listening to this podcast and this is starting to make sense. And maybe this is something I want to do. Maybe I want to do direct care, whether it's direct primary care or direct specialty care. And this guy Aguila keeps saying, that Phil's got some great resources. So I want to dive into the direct primary care frontier. Tell us a little bit about that, and what the genesis of the DPC frontier was.
I'd started making outlines, dating back many years, probably even first year of med school, when I'm supposed to be studying biochemistry. I was still doing some of this stuff, and trying to think about, okay, how does this fit here? How does this fit there? But I really didn't put the website out until around 2014, and I was still a resident at the time, but I started aggregating just where all the DPC practices were. I'd kind of read about 50 or so of them, and I was just doing these really, I was on the 10th page of the Google search, if you will,
Sure.
just looking for anybody who'd even uttered this phrase, trying to see, okay, is this a DPC practice? Is this one? Is this one? And I came up with a list of, I think, around 100 to 200 practices. And then I started doing an analysis of those that ultimately became the genesis of a paper that was published in JABM, and said, well, I found this geocoder that would allow me to map them. And then I'd done a bunch of legal research, and I thought, why not just put this out there so other people can see it and patients can find it? And I knew that the mapper would be a patient-facing feature, but it would also be good for other DPC physicians to find each other. So that's how the mapper started. And then I'd done a variety of legal research already, and just started building out different aspects of the website for physicians focused on their common legal questions.
Sure. So if I'm a medical student, or let's say I'm a resident, I'm a third year resident in family medicine, and I'm trying to decide, do I do this direct primary care thing or not? There's a lot of great resources there on the DPC frontier. Where would you recommend they start if they're thinking about either starting up or joining it? Obviously, it's easier to join an existing practice, but let's say we have somebody who's particularly entrepreneurial and wants to start up their own practice from scratch. What's your advice?
I'm going to sound like a realtor, I guess, at the beginning. Location is the first thing I'm going to ask. So a lot of people come at this and they say, well, I've always lived in, Central Arkansas or wherever, and they're going to live there. So, okay, fine. If you've got family there, then that's already set. But if you don't have that situation, if you could go anywhere, then there are some states you probably should avoid, and others that make this much easier. So there are state by state pages on there that will issue spot whatever's critical to you in your practice. I also had an article published in the Journal of American Physicians and Surgeons a few years ago about best state to practice medicine. So I'll mention a few of the rules. New York, New Jersey, they make this hard, much harder than it needs to be. And they give unfair advantages to groups that are larger and got limited, that can meet the requirements of what's called a limited service HMO in New York. That's about the only way to get transparency on labs. You can't dispense medications in either state. So there are some places where they make it tougher. Texas is like that too. They keep you from dispensing medications, and they sort of surprise people at how hard they can make it sometimes. There are weird quirks. If you like rural medicine and you manage to get 10 miles from a pharmacy in Texas, which is harder than it sounds, you can dispense. So these kinds of rules are stuff that I would love people to sort of look at as they're contemplating not only what state to be in, but literally where to be in that state, because they might find that there's some quirk that they didn't know about that's going to make all the difference in how successful their practice might be, especially at the beginning, where the smallest thing can lead to exponential growth and you didn't even predict it. So venue's a big one. We talked about some of the regulations that can vary state to state there. If you're going to have any non-physician owners, which can be important if you're going to have 5-6 practices and you need somebody to back you, and it's not going to be in the form of a massive loan from a bank because most banks don't know what this is, then corporate practice of medicine can come up. And weirdly, those laws you would think would help the smaller docs who want to do this, but they're often written to help the large hospital systems and be a burden to the smaller doc. So that can affect how people can invest in your practice and make it harder in some places than others. So legally, those are the things I would look at from purely a medical standpoint. See how many other people in the area are doing it, and you might look at the mapper and see 3 practices in one area and think, oh, that's too many. I can't be the 4th one. You'd be surprised. You might benefit a whole lot from 3 practices in the area that are popular and full. And now people aren't calling your office saying, what is this? They're calling and saying, are you full yet?
Right.
So that other people in the area already educating specialists and already asking for price transparency can save you a lot of time too. So going someplace that already is geographically aware of DPC and already has a price transparent mentality can be a big plus. And so that can surprise people. So if you're the first one to do it in your community, it is harder. The Dakotas were the last ones to have DPC practices, and for the first one that showed up in the state, it's like they had the same insurance commissioner conversation that for other people took place decades ago.
Sure. So there's one thing I want to make sure that I highlight from your website that I found so tremendously helpful. And again, I'm not a primary care doctor, certainly not any longer. And so you might wonder, well, what's in it for me as a specialist to go to the DPC Frontier website? In my case, the section that you have on the website that deals with Medicare in particular was so valuable to me. I mean, threading that needle, being able to, so like initially there were times during my practice early on when I did some locums work, right?
Mm-hmm.
And if I were to opt out of Medicare, I mean, a lot of these locums companies aren't interested in working with me then. They're like, well, how the heck are we supposed to bill for your services if you opt out? Well, it
Right.
turns out there's more than one way to skin that cat and to be good with the law, still be true to your principles, and still give yourself the flexibility and the resources that you provided there. And then of course, the conversations you and I had specifically about that were amazingly valuable. Can you talk a little bit more about that Medicare piece?
So I'm happy that it was useful for you. The Medicare section is always a source of confusion, and that's by design. 99.9% of patients or physicians are participating in Medicare, which means that you're fully credentialed with them on their terms. There are other statuses that we can be aware of, and the name doesn't do any of them justice. It creates further confusion. So there's also a non-participating category, which I think is one of the most useless categories, because you still have to bill in their way. You still have to use the codes they know and the language they know. And you get a little bit less from Medicare with the option to charge the patient what amounts to a higher copay. Whoopity-doo-dah. Doesn't really make a huge difference. I don't know anybody doing that. Then there's opted out. So you've got participating, non-participating, and opted out. Opted out, contrary to the name, means that you're still credentialed with Medicare. They still know who you are. They still have your NPI on their list, and you still have numbers that DME companies can reference and say, okay, yeah, this person's known and they are credentialed and they've not been kicked out of Medicare. There's disenrolled, which I don't recommend you do, but it is another, at least theoretical category. And if people are really interested, we sometimes get into the weeds of what legal theories would be there and how you could, do all kinds of funny things, but I'm not going to spend time on that here. It's going to confuse people. And then there's kicked out or disbarred or decredentialed, which means, maybe you spent some time in a federal prison because you were, inappropriately billing to the tune of several $1 million and charging for work that wasn't done. And those physicians are literally not allowed to participate. Too often, hospital systems and other employers that you might talk to here opted out, and they think the last one. They think, oh, this person's been kicked out. That's the last person we want here. Or, oh, they're not credentialed with Medicare. All of our other payers are going to look at that and freak out. So if you're looking at outside work, you've got to remind them, you might even phrase it differently. I'm still credentialed with Medicare. I can still order things for them, but I am not billing under them, and I'm not allowing you to bill for my work under them. Is that okay? And you'll get different answers depending on how educated they are. I've had DPC physicians that work with the VA, which theoretically is only billing itself. Sometimes they do secondary billing where they'll pursue reimbursement from another entity, which would make sense for Medicare Advantage to me, because then the government's taking money back from an insurance company, but not for regular Medicare. But supposedly they still might do that. I've had different physicians get different answers. Some of them were told, oh, you're opted out. I don't give a hoot. That's fine. And other places, they won't let them join. So I think the right answer is that they should be able to join, and in the rare circumstance, they just wouldn't bill back on themselves for that 0.01%. There are also times when, if you've opted out, you're allowed to bill using a JG code for urgent care or emergency services, and they pay you about 90% of the regular rate. The caveat being that you can't see a patient that you already have a private contract with and then charge in that emergency setting. If they happen to, the person who comes in with 10 out of 10 chest pain is your DPC patient, then you're providing care for free, basically, is what that amounts to, because you've already got that private contract with them. You can't do any emergency coding under that provision. The reason to opt out is because if you want to have a private contract for covered services, this is the only way the government will let you contract with them to do that. So a lot of people, will see this mentioned at a conference and they say, well, you're not patriotic if you're opting out of Medicare. That's not good. And I say, wait a minute. The only reason I'm opting out of Medicare is because I want to see Medicare patients for covered services under a private agreement. All three of those have to be true or I wouldn't do this. So do concierge doctors who charge $5,000 a year opt out? No, they bill Medicare and they bill additionally to that. Do pediatricians opt out of Medicare? No, they don't have any Medicare patients. They don't give a darn. Unless they had a rare child who comes in with chronic kidney disease, that's about the only way they're going to have a Medicare patient. So the folks who are most likely to opt out historically were actually psychiatrists, because Medicare pay was so poor for psychiatry, and they were doing that to continue being able to see those patients. So I tell people this is a patriotic thing in my mind, because I'm seeing Medicare patients for an affordable price that they're willing to pay, and I'm not charging the government a dime. So that's the irony that you find yourself in here, sort of explaining all this. And the thing that annoys a lot of physicians when they look into the details is, whatever decision you make, you've got 90 days to reverse it and say, oops. But if you go past that window, it's a rolling 2-year window where you have the chance to change it. So if you get to let's say you start a DPC practice and you opt out right away, and then you get 5 months into it and you're like, you know what, I don't like this for whatever reason, I want to go back and do something else in the system. Well, you've got another 13 months, or no, 19 months until you can fully participate in Medicare again.
Yeah. Well, that's really useful, and thank you for that summary. Because, like I said, I spent I don't know how many hours poring over that page on your website, and then obviously sending you a bunch of emails and having conversations with you. So, for anybody out there, I don't care whether you're. Let me rephrase that. It's not that I don't care. It doesn't matter whether you're a primary care doc or a specialist. That if nothing else, that page it's a gold mine, and I highly recommend it to anybody and everybody that's at least curious about how to thread the needle with Medicare and how to keep yourself out of trouble and to take good care of your patients. Now, as we finish up here, Phil, I have one last question for you. The same question that I ask everybody who's a guest on my podcast. Okay, our our listeners are medical students, residents, fellows, and people who are fresh out of training. Primarily, I mean, there's a lot of other people listening too, but that's our target audience.
Mhm.
What advice do you have for them? Particularly for those who are considering either direct primary or direct specialty care. What do you want to tell them? What do you wish you had known about this when you were in their shoes?
I'm a weirdo. I was always looking into this. I think what I would say, one of the things that frustrates me most in medicine or any field is this sort of guild and guideline mentality of, no, I'm this specialist, so this is the guideline we use. We don't care what you all have, and I'm not going to study how you came to that or what your data was. And I'm going to sort of defend this turf. And there were plenty of times when I was a resident and we're doing hospital rounds, and what started as an intellectual discussion ended with a hurried specialist uttering the phrase, "So that's an indication for." And I hate that phrase because too often it means we're going to stop looking at the big picture now. I've already decided that this particular procedure is the next step. And until we have that, I'm going to put my blinders on and not think about everything else. So I've never liked that phrase, and to me, it results in a lot of wasteful spending and failure to really articulate and do a good job at informed consent. So if you're somebody who's in training and you hear that, hopefully you have enough energy to read past it and read around it. Is what they're doing really affecting all-cause mortality? Did they really go over all the alternatives? Does this particular specialty approach for this particular disease make sense in the setting of all the others? And that's the skeptical mentality I think you have to be a good primary care physician, because we often find ourselves in the position of, frankly, auditing the recommendations that specialists make. If I work somebody up for a complicated lupus situation, I send them to rheumatology and they don't read my note and they reorder a bunch of tests and they charge the patient $3,000 for all those tests that were reordered and give advice that was duplicative, that'll be the only consult they ever get from me.
Right.
So I think too often in training, we just sort of take the guidelines, take the algorithms and march down them. And I know that you don't have time to go look at the primary sources for everything. You can't read every research paper out there. But I think you can come at it with an eye of skepticism, and you can see where other people have argued intellectually, and never just accept one side automatically. Always look at both sides, and always keep your differential as broad as you can so that your informed consent can be as good as possible. And then you'll be just fine.
Awesome. Well, thanks, Phil, for taking the time to be with us here on the podcast today. I'm Dr. Demetrio J. Aguila III. I'm your host for the Direct Care Movement podcast. We were excited to have Dr. Phil Eskew as our guest today. Phil, how do people find you?
So my website is www.dpcfrontier.com, and my email is phil, PHIL, at dpcfrontier.com. I would tell you to go to Twitter, but I really just haven't done anything on there in a while. I'm not a good social media person.
Sure.
And my Facebook page is similarly quite atrophied. So if you want to get me, I'm a little old fashioned. It's going to be on the website or email for the most part.
Awesome. Well, I will tell everybody the email works. That's how I've gotten a hold of Phil every time, and thankfully you're very quick to respond, and your answers are always really, really informative and helpful. So, thank you for all of that, Phil. And on behalf of all of my patients who have benefited from the work that you've done, thank you again for laying the foundation that so many of us have built our practices on.
Well, thanks, Demetrio. It's been a pleasure chatting with you today.
It's been great chatting with you too. Thanks. Thank you for joining us on the Direct Care Movement podcast. We're excited that you joined us, and we're looking forward to having you join us in future episodes as we dive into more questions and more concerns and more solutions in the direct care space, whether it's direct primary care or direct specialty care. If you liked what you heard and you want to know more, please click like and subscribe and leave us a review. And don't be afraid to reach out to us directly so we can get you more information about direct care, whether it's direct primary care or direct specialty care.